Hello everybody, this is the first three-step concert, and if I don't have a heart attack in this moment, it will be one of many concerts. I understand why people get drugs to be on stage. I'm not on stage, I'm in this little studio. But I'm telling you, the pressure is huge because our presentation is connected to a little cable. And if something does not work, we don't know what to do. So, seems that everything is fine. I don't even know if my girlfriend, that don't even know anything about dentistry, are trying to connect people all over the world. So while everybody tries to get into the link, let me start with this three-step concert. The idea behind this first concert is to discuss about teeth, and I selected a special topic. The special topic is really the three-step word. So here many of you know already what is the type of job that I found, I created. But I want to make, in this concert, I want to give you the reason why I'm doing the things that I'm doing. And that's why I don't want to be by myself, and to start the concert, I would like to have a guest at the beginning that will be with us, and let me introduce you to Dr. Miguel Ortiz. Miguel is a prosthodontist, and many of you, he has 300,000 fans on Instagram, so many of you are already familiar with him, and I let Miguel introduce himself. Ciao Miguel!
Ciao Francesca, how are you doing?
I'm trying to survive to the technological stress.
You're doing awesome. You're doing awesome. So whichever drugs you're taking, can you send some this way?
I think it's fantastic. I'm really glad that you find also from your side this type of experience. That is not your first live. Have you done recently something similar?
We've done. I know the pressure you're feeling because about 2 weeks ago, and hello everybody from all over the world, how are you doing? I'm here in Boston in the United States. About 2 weeks ago, we did a live course right here from my office, where we started in this office with like 5 or 6 cameras, and I gave a lecture, and then I moved to my operating room where I had another 6 cameras, or five, I think, and we did a full anterior veneer, six veneer case prep, impression, temp, and one posterior tooth that I prepped, scanned, designed. Then we moved to the lab, we milled it, and then we cemented. And I can tell you, if you're a doctor and you're depending on technology for your colleagues to see you from around the world, it is frightening. So I know what you're feeling, but this is going to be amazing.
In fact, we have to be dentist, we have to be teacher, we have to be photographer. Now we have to entertain because it's Saturday night, at least
I
in
can dance,
Europe.
huh? I can
That's
dance.
like, no, can you dance?
I can?
No, I can dance. What are you talking about? I do
I can
dance.
dance if we
I
need to.
dance. What do you dance a tango as an
Oh,
Argentinian?
there might or might not be a video on YouTube of some crazy Argentina dancing tango. You guys are gonna have to find it.
You
Maybe,
dance.
maybe.
Okay, I will go and Google because
Oh,
I want to
I'll
see
send you the
your
link. I'll
skill.
let everybody else have to look for it.
But you know that I had once a congress in Argentina, and I asked, it was 700 prosthodontics, I say, is there anybody dancing tango with me? And they say, we Argentina, we don't dance tango.
We don't.
And my
That's the
heart
truth. We don't.
break. Tell
It's
me it's
true. We
not
don't.
true.
We play
It's
soccer
not,
though.
it's not true. I am
That we can
so
do.
sorry for that. So, but how did we meet, Miguel?
How
Because
did
it's
we meet?
been
We met because you are too kind. That's how we met.
all
Because
right.
I reach out to you and I say, Francesca, We're in the middle of a pandemic, and I admire you a lot, and I know what you do, and will you like to share it with everybody? And at that point, you were kind enough to join us and give us out of the bottom of your heart, from your home, very late,
Right.
3 hours of your knowledge, and that's how we met because you're too kind.
No, but because this is the problem when you give the power to women to speak. And we have to say that dentistry, let me do some pink power moment. Dentistry is going to be pink because in dental
Good.
school, the majority of the students are girls. So in
Yeah.
the future, more and more, we will need also speaker,
Yep.
female point of view. So
Yes.
just not to put you in trouble, but
No, don't
it's
put me in
because
trouble. I am a big advocate for women on the stage, and one of the reasons why I sometimes butt heads with some of the big organizations in the United States, such as the ACP, is over this issue about the amount of female speakers on stage.
yeah, but why they don't want them? No, it cannot
The big
answer.
old
Okay,
guys.
next
The-
question.
no,
Next.
no, 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 no. I'll go to it. No, 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 I'll go to it. No, I'm not gonna be like, oh, I'm afraid that I will never be called by the ACP if I answer this question. No, F that. I think that the way some organizations been running is the old boys always invite the old boys and they scratch each other backs. That's what it is.
Okay, I think after this concert, I will again be on the bad guy or bad girl list. So this is my
I've
problem
never
that
made
I
it in, so
always.
I'm not fine. I'll stay
Uh,
outside too.
I think I am get always in trouble. But so tell me, why did you decide to become a prostodontist?
Look, it's
First of
very
all, can you
interesting.
tell
Yeah,
what a prostodontic is? Because not everybody knows.
you gave me two questions right there. I'll answer the second one first, and then I go to the first one. What a prosthodontic is might change based on who you ask. If you want to ask those program directors in academia, at least here in the United States and sometime in Europe, they're going to tell you that we are the quarterback of the team and that we tell the other specialties what to do and that we know better than everybody else. And
Okay.
then if you are humble enough to come out of that idiocracy, you realize that we are one more in the team, a very important part of it, but we're not better than other people. And that we should be part of a team that can see the mouth as a big picture instead of as a little piece. And we can do that from the side of materials, occlusion, restorations, implants, and mechanics or biomechanics. And that sometimes we need an orthodontist next to it, or sometimes we need a periodontist next to us, and sometimes we can have a general dentist right next to us. So it depends on who you ask. If you ask some program directors, they will put themselves higher than everybody else. I don't put myself there. I think that I know some things and I can see mouths in a different way than other people that weren't trained that way. Not that they're not smart as me, that weren't trained that way, but that sometimes I need, many times, a surgeon, a periodontist, an orthodontist, a pedodontist to tell me also how to complement. So that's what I think a prosthodontist is.
But which is the population that you are treating if you want to make a percentage?
Many
Like,
people think that, again, if you go to a pros program here in North America, you're being trained to treat the full mouths that are destroyed and the older population that being treated a lot. And that means sometimes that you're being trained to overtreat, in my opinion.
so, but right now, if you have to suggest to somebody that wants to become a prosthodontics where to go and look for training, what would you say?
I get that question all the time. As you say, I don't have 300,000 followers, but I have 200,000 followers. And I get that question all the time. And what I say is, if you're coming right out of school and you want to be a prosthodontist because you know that what you learn in dental school is a little bit limited, it's focused to one tooth, maybe two teeth, maybe a crown, maybe a filling, maybe an endo, but you want to know how to take the hard cases, if you're coming right out of school, do go to a prosthodontist program, but do understand that you're being trained whatever that program wants to teach you. And there's many things that that program do not want to teach you as well, because there's a lot of dogma and politics involved. So you can go to a prosthodontics program, get your feet very wet, get a lot of clinical experience of doing full mouth, but your brain has to be open to understand, okay, what are they not teaching me, and where are they straight out wrong,
But
and
what
how can
about
I complement that?
evidence-based dentistry to guide
Yep.
us?
Which evidence? Because if you see what I do in social media, I am all about the literature and the evidence. But dentistry is complex in a way that research is really hard to be done. Clinical research is really hard. I'm not going to spend the time of my clinic that every hour has a dollar sign next to it, creating a protocol and calling patients in to see if they're feeling fail or not, so that I can fill up a form and then publish a paper. So most of the clinical research is done in schools because the students
Yes.
need to publish. But those students are there for a limited period of time. So most studies that are done have a student with a biased goal, which is to finish the study. And these studies are usually short and non-consequential. So we have this intrinsic problem that we don't have good research. So we can do evidence-based dentistry, but with the evidence that we have. And sometimes we need to make a leap of faith towards something. Now,
So
that is
it's
very
more.
different that is very different than saying I'm going to do whatever I want because there's lack of science, which I see many of our colleagues doing, which is they use as an excuse, well, there's no science that shows that X, Y, Z. And I'm like, actually, there is. Have you looked for it? So we have to be careful where you stand there.
But I would say I want to bring up an article. In
Hmm.
all these concert,
Show
there
me.
is one article that I would like to discuss with you. There
Show me.
was
Show me.
an orthodontist, Dr. Lang, that wrote an article on us, dentists. I don't
Yeah.
know, it was not focusing on a specialty or general dentistry. It took our medical record, our life, and it came out with a list of problems. And the conclusion were that our life is miserable. So let's see if in this pandemia and post-pandemia, the reason why our life miserable will be better. Do you think economic pressure will improve? People will invest more in teeth?
Are we talking about the patient side?
Yes.
No, less.
And the cost for our office raised so much.
Yes.
In a intraoral scanner, 40,000, microscope, 40,000. So it's not small things, big machine to buy. So this is a problem. The patient with less money and we with more expense. What about time pressure? How many patients do you see a day?
Hmm.
What is your choice?
You want me to tell you how many patients I see a day?
Yeah, in general.
5 to 6.
Okay, so I sometimes I give courses and I have dentists that see 20 people, 30
Hmm.
people a
Yep.
day. And when I look at them, I see that they are a little bit frustrated with the treatment
Yep.
because now you have many patients, and at the end of the day, maybe with 6 patients, you do the same number of teeth, but in a different condition, because
Yes.
you don't do. You don't make the patient go in and out of your office. He's sitting there for a reasonable amount of time, and you work on more teeth. But for me, the things that I really felt in my education was this patient anxiety. Do you have sometimes when you are touching these people that they are so scared, like a
Yes.
little baby, they start to cry. I don't know how pedodontists can do that. And they cry, and when the patient go away, you feel that with him or her, it went away like 5 years of your life. Do you recognize our miserable life in this work of Dr. Lang
Uh,
or
I have
not?
I have two answers for that. Yes, I recognize it, and most of the time, it's the fault of the dentist. I know you didn't want me to go there. I
No,
know,
no,
but you
no, no, no,
invited
no,
me.
no, no.
You invited me.
No problem.
Uh,
Hey,
for
hey.
for me to come here and say to the world, even though only dentists are listening to us, to cry out that our life is miserable when people are out of a job and the average person has a worse job than we do, it will be disingenuous. But I do recognize that many of our colleagues are in situations that make their life miserable. So what I say is, what is making your life miserable? The income pressure, the fact that you cannot do many, the fact that you see 30 patients a day and it's driving you nuts, the fact that every patient that you see is a crazy patient, you find yourself in a situation that makes you miserable, get out.
Okay, but for instance, there will be different type of dentistry. Let's talk about choice. So there are people that are super happy the way they do dentistry, and there
Mhm,
are people that are very unhappy. The super
mhm.
happy people have this type of population that I call the Gisele Dentistry. The Gisele Dentistry is what we see all the time. So you see this beautiful girl that don't need any restorative, but they get aesthetic, that is composite or facial veneers. But here I see all the teeth. I don't see any cavity, I don't see any periodontal problem, I don't see any missing teeth. So they have a nice life. However, this is not what we can have in our private practice, because I think, especially if you see again on the social, I am a big fan of these women that can put so much makeup and they look amazing, and I have even one little foundation and they have 6 7 and it looks a piece of
They need
art.
to look at you because you look amazing with a little
Oh
foundation, and
yeah,
I don't know why they're doing that.
I swear I don't pay him, but it's such a nice
No, no, no.
galantuomo, we say in Italian. So the thing is the reality of the rest of the dentist. What happened is that in our closet, we start with the career that we do with years to accumulate skeleton, and this skeleton will sometimes pop out. So I always say to myself, when I see a panoramic, the quantity of white tells me if it's a good day or is a bad day. So when you see in your office
I like that.
this type of panoramic, you know it's not a good day. You don't need to see the patient that is coming to you. So this is, Miguel, these are the people that should go to a prosthodontist. That's what we were doing in
Hmm.
prosthodontic school.
Hmm.
We were doing with this
Yeah.
disaster. So the thing is that it seems in our community that this is what we have to be doing because the patient age, and there is no alternative, because this woman, she started when she was 60 and somebody promised her that she should never have the removable. Now she's 80 and that patient, that dentist, that promise is not there anymore. But there is a skeleton and the locket is open and the patient is aging. And the question, like you say, was something that could be evitable. So this patient could have had a different approach starting from us. Because what I see is that we keep believing in technique. I don't know if with you, Miguel, if they are interested in which type of adhesion, which type of composite, which type of ceramic, and I think this is technique that could change, could improve. And you say material are really the hottest topic, because you know the problem is that my material is this, everything else no good. So no, we can discuss for hours which is less worse, but for me, if I can have enamel, my life is beautiful. And at the end of the day, like you say, we can always blame the patient. How many crazy patients we have, how many Braxer we have, how many patients don't come for recall. But Miguel, when you see this project, can you really blame all this fracture to the patient? Because you
No,
should have had...
no, no. That's a lack of planning from the first dentist that saw the patient till the last one, or wrong planning or misplanning on this case.
But we can say that these dentists invest a lot of time and money in
Yes,
the
yeah, they meant
dentist.
well too.
So I think you say, for me, three people are here, and all of three have a problem in this moment. The dentist, the patient, and the lab technician. All of three are in trouble, unless one of the three move away and there is another to replace him.
Yep.
But these three people, the team, has a problem because all of the three are suffering. The thing is, once upon a time, there were beautiful 32 teeth. Now the eighth molar, the third molar is gone. Nobody wants to see that. But the question is, when you and I graduate from the Prost at 2003. You, which is your graduation? When
2014.
became, before me or after me?
No. Whoa!
Oh,
I was being nice.
no, because I'm late. I'm a late bloomer. I
I'm all
did
here being nice, and it's like
no,
2014. No,
because
I'm kidding. I was a dental technician for about 10 years, so I bloomed late too. So when you were
no,
in school, I was a technician on that trifecta.
but you know that the best prosthodontics that I know were laboratory technician. For me, the fact that you say that
You
you
want to
were
know
a
why?
laboratory, because
Because
two of the three people of the team, they understand the problem and the
I'll
solution.
tell you why. Because when I was a lab technician for 10 years before I went into dental school and before I became a prosthodontist, I did the work for about 150 dentists that will send the work to me. So I learned to look at what they were doing, and I learned what I wanted to do when I became a dentist. I said, I'm definitely not want to be that guy, and I don't want to be that girl. I want to be like that girl that's sending me all this amazing work, this beautiful prep, this good impressions. The one that picks up the phone and she says, Miguel, I'm about to send you this case and I think we need to discuss it together. So even before going into dental school, I know what kind of dentistry I wanted to do. Has nothing to do. Many people say, oh, because you already knew how to wax. No, no, no. It had to do with I knew what I wanted to do.
Okay, excellent. I didn't know you were a laboratory technician. For me, it's fantastic. So when I start all this mess that I have done, and I apologize if this presentation will hurt some feelings, but it's not meant to do so, is to meant to help, to move to another level of awareness. When I started the pros, this is what was our goal,
Yep.
to repair this teeth.
It still is.
Yeah, nothing changed. And I felt that, yeah, this is good for the first dentist. But I would have never been the first dentist. I would have been the following dentist. So if you see this woman, she is just 37, 37, and she has at least 50 years in front of her, and she is already at the third remake. So, Miguel, this is in your office Monday. This is post, zirconia post, all periapical lesion, canine fracture, a total deep bite, patient with no time because she doesn't have time. She's a clinician, she moves around. Good news for you?
I don't want to see that on my chair on Monday morning. No.
So, this, your blood pressure will pop up if was your everyday patient
Yeah.
with no percentage of tooth structure. And just tell me, because I think you are excellent the way you deal before these things that was going on with my perfect assistant Gisele. We were completely
She's so awesome.
almost. No, it was almost not coming this concert, and Miguel was like, "Oh, it would be good, it would be fantastic. Don't worry." So I
It
know
is.
you are a perfect coach. So can you tell me, when you finish repair this teeth?
I don't know if you guys can see. Oh, okay.
Now, can you see now, because the
I can
camera
see you
once in a
now.
while
I can see
so
you now.
when the patient doesn't want implant, he wants to save these teeth, which guarantee? How long do you tell they will last? Do you speak about
You
longevity?
should. I think you hit the nail on the head on that one. You say the patient doesn't want implant, and the reason probably that the patient look like it looks right there, and we're just making a hypothetical patient right now, is because probably the patient drove the last treatment as well. Okay, because probably those teeth didn't need to be were too far to be restored to begin with. And now she comes again and she said, "No, I'm not ready for implants. Please restore them again." And then in 3 years, she's sitting in my chair after coming from your chair, and I have to restore them again. So what I feel from that story, and I know that it's not where you wanted to go, is many times is the dentist's fault, but many times it's also the dentist's fault that lets the patient drive the treatment. Because if that patient sits in my chair and said that she wants to restore all those teeth in my office, they don't get restored. Because if the
Okay.
last post and core, all set of post and core lasts you 3 years, what makes you believe that my set of post and core is going to last you another 10 years?
But these people come to you and they remember the first dentist and they
Mhm.
say, but the first dentist did this work and last 20 years.
It didn't.
No, it's true, the first dentist took
No,
a
but it didn't last
perfect
20
tooth.
years. That's what the patient thinks. The patient thinks that because it stayed in the mouth, that it lasted, and it's not the same. If you
Okay,
look at those teeth, they fell 10 years ago.
you're right. Oh, there's an excellent point of view.
So
But you
that is
know
the
what?
conversation that I will be having with the patient.
But you know what is when I used to live in the United States, I was also with the idea that thank God we have implant. And you know why? Nowadays we came out with the population that is not aging the way we thought 20 years ago. We have not only biphosphonate, inhibitor of the pump, H pump, things that before we didn't think could create problem to the bone. So I'd say that this is becoming a big topic in the big surgeon. Now they are making a step back. I don't know if you see, but before I
Yes.
was in the
Yes. I'm part of that generation. I'm part of that generation that we are telling now our patients, implant is my C option, okay? It's not even my B option. Implant is my C option. Maybe for the generation before me, when we kind of got too comfortable with implant, everything was like, oh, don't worry, we'll take that tooth out and we put an implant. The first generation of implant placers were like, I don't know if the implant's gonna work, let's be careful. Then the implants work and it's like, oh, this is great. Pull it and put an implant. And now we're like, some of us, especially on the education side, we're saying, hey, hey, hold on. No, 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 no. And especially in the anterior sides. Especially. I get this all the time. Patient sits on my chair, 16 years old, congenitally lateral incisors. They're coming from ortho, and the mom said, we're done with ortho. They told us that we're going to wait 2 more years for the implant. So what can you do until then? And my answer is, Mom, you don't have to worry about this. Why? Because you're not paying for this implant. What do you mean? She's going to get that implant when she's 40. So you're out of the picture. We're going to do a resin-based restorations here, and you don't have to worry about it.
absolutely.
Because we're starting to see what happened with all the implants that we put in the 90s and the 2000s, especially on the anterior region. So yeah, I'm agreeing with you. We are revisiting everything about implants, and I hope that our colleagues can revisit that together.
Absolutely. Amen. So, the next dentist that takes this beautiful case that is perfect if you think
Yeah.
about it, the 4 millimeter to the apex, the post, but it's brittle. It's brittle because if you lose this, the whole thing's break. If you start to chew on the other side, maybe this one it's overload. And if you lose both sides, and this little guy can start to fracture one after the other. And now we go to expensive treatment, complex procedure, no guarantee. This is the next dentist, not the first one. So this is the way we may have this patient age. And you know, I have my partner in business, and he is in 60s, but his population is in the 80s, and he is also aging. So he's treating this population that is difficult. It's difficult, it's not only about money, but the procedure are extremely difficult. So let's comment together, Dr. Lang, because yes, I agree with you, Miguel, that we should not
Let's do it.
complain because there are people in the street, there are people with no job, but we also should be aware that we could do a beautiful type of dentistry, beautiful type of job
This
in
is
a
what I
better
say.
way, in a better condition.
This is what I say.
First killer. I mean, how do you check your blood pressure every day?
This is what I want to say, and I'm gonna stay on the same path with respect to this article and with respect to this. When I see those X-rays Monday morning, I know it's not gonna be a good day. It's not gonna be a happy day. Maybe it's a good day for my bank account, but I'm starting to feel like it's not even worth it sometimes either. Okay, but
Exactly.
if that is my Monday morning, and then something similar on Monday afternoon, and something similar on Tuesday morning, and something similar on Tuesday afternoon, and I am that subset of dentists who don't like that, then if you stay there, then it becomes your fault because you can decide most of the time to work somewhere else when that is not that you see all over. And I know that because I did it myself. As a surgically trained prosthodontist, when I just came out of residency, I was doing a lot of full mouth implant surgery and bone grafting and augmentations. And I found out that even though it's good for the money, I don't enjoy doing big flap surgery. I just don't enjoy it. I am average at it. I am not great with bone graft. I'm not good at fancy suturing techniques. And I am good at aesthetics, at prepping and impression and thinking about the case. So I know what I'm good at and I know what I'm not good at. So what I had to do is at some point say, I don't want to work in this practice anymore. Nothing wrong with that, but I'm going to go to a practice where I can still see that maybe 10, 20% of the time because I need it in my bank account. But the other 80% of the time, I do things that don't get my blood pressure raised. So that's what I mean by if you are hating your profession because of the type of patient, the type of material, because you see too many patients, because your boss force you to do treatment that you don't want, eventually, if you stay there, it becomes your fault.
Absolutely. So, but you guys, can you understand that our suicide rate is twice the rate of the general population that is not doing very well? If you think about the amount of antidepressant and anxiolytic drugs that they are taking, the emotional illness from burnout to depression ranks third, where in the general population is at the 10, number 10. So we are really at risk. And I can tell you that when I was doing the type of prosthodontics that was a classic, I have had back pain, stomach ache. I was just not happy. And so the question is, can we change? And my answer is that must. We must, because life is too short and this
Yes.
pandemic is teaching us that
Yes.
life is way too short to not to walk the talk. So the question is that when I was at prosthodontics, I didn't have a choice, but I created the choice. So, but first, Miguel, let's start with the awareness, because I have this baby with these eyes that is always pumping my mind when I do things, because I always want to know why I'm doing what I'm doing. We need to stop with the excuse, and I want actually to quote my second article, but this guy did not wrote a real article that was accepted officially, but it was 4 centuries before Christ, Plato, a philosopher, Greek. So he was talking about the type of medicine, and he said that actually there are two ways to be a doctor. There is a medicine that treats the slave. What does it mean? That the slave breaks something and stop working. So the slave is brought to the doctor that has to fix it, the slave, because he has to go back to work. This is a dangerous type of medicine. The second medicine, Plato was not looking at women but at men, the free men, because there was slave and free men, and this type of medicine instead, before repairing the problem,
Excuse
was
me.
interpret to try to remove the cause that has brought to the problem, so the problem will not come back.
We still have this today, yeah?
Yeah, it's if you read the real, it's not in ancient Greek, it's been translated. If you Google, you can find the exact definition, what he wrote, and it's so similar of what we do. And so I want to, in a polemic way, to talk about single tooth dentistry, because in dental school, we always are taught to do single tooth dentistry, like you say, a little
Yeah.
composite, a little co-crown, a little fillings, with just a repair. But that could be good if you have a caries that is arriving to the pulp. So I can justify this because the patient will come in pain. There is less money involved because it's a single tooth. The patient accepts the treatment because many times it's the patient that calls for the appointment, and the occlusal adjustment are easy. Why? Because we basically put the tooth in not occlusion, no?
Yeah.
They just say, it will come
Yes.
out, just remove everything. But let's discuss this picture. Is this a slave treatment or is a free man? Because here I see the interesting in the most important teeth, the anterior teeth. And even these two crowns present a failure already. And what about the rest of the mouth? And this patient has already paid for more than 1 crowns. So the question is this a dentist that is treating this patient as a slave or as a free man? Because in every patient you can recognize the attitude of his dentist. Here we have a maxillary, except for these few teeth, already in ceramic crowns. So it seems that he's doing a global project. But what about the mandibular? So we have ceramic against exposed dentin. And in the same patient, are we leaving the pulp like this? In an erosive environment, are we really doing a global vision? Because, for instance, Miguel, if this patient that has done all his life a little dentistry, single tooth dentistry,
Yeah.
come to your office,
Yes.
how do you speak to him?
I
This is him.
I learn, and I think your presentation is good because I know where you're going, or I think I know where you're going, and how you're bringing it from very different angles. We started talking about the dentist, and now we're switching about the patient, but in reality, we're still talking about the dentist, and that's the genius of what you're doing. My life as a dentist has never been miserable, and that's because I'm lucky, okay? But it is also because at one point I learned that I should not underestimate the patient's ability to pay or understand me explaining them the proper treatment that they need. And let me explain that. This looks like a patient that every time he came, a little fire was put off. A crown here, a filling there, a crown there, a filling here. The reasons are usually financial, right? And when you, let's say if this patient was treated only for one dentist their entire life, the first time probably the dentist says you need ABC and the patient said like, I can only do A. Okay, we do A. The second time you need ABC and the patient say I can only do B. Okay. The third time the patient, the doctor say you need C. Like I'm not gonna waste my time explaining, I know you need a crown and you're gonna say a crown. So at one point, when we see 100 patients and we spend 30 minutes telling this patient what they really need, and at the end they only pick a crown when they need more, or they pick, you feel like you wasted 100 times 20 minutes. And it gets to a point that we actually stop doing what we need to do, which is we should always keep continuing to tell the patient what they need to, even though if we know that they're going to say no, because that's our job. So then we become, patient comes in like this, one of those crown breaks, you say, let me fix it for you. Maybe I can do a post and a core and a crown. Maybe I can do an implant. We already assuming that the patient is not ready to hear that they need whatever in this case they will need, which we know is much more than a crown. And I think we're all guilty of that. And I stopped doing that. Everybody in my office will hear what they need. And they will hear the pros and cons of doing A, of doing B, and of doing C, and the pros and cons of doing nothing. Then they get to decide if they want a crown or not. And I will be damned to show you how many patients walk in and you said, there's no way that they can understand me, or there's no way that they can afford me, or there's no way that they will do it. And it might take an appointment, it might take 3 months, it might take a year. And then one day they sit down and they say, last time you mentioned how this is a mess. What did you say that I needed to do? Because I've been thinking about it. That's what I think the
When I
biggest
do
problem is,
the
that we stop
majority,
telling the big picture.
I was looking at my patient and I realized that I always say 80% of my patient is a full mouth. And I will tell you, I will show you the
Yeah.
cases. And people say, hey, but they come to you. No, I transform these people in people that will have a full mouth. And I will tell you in which way. But why I do that? Because when I see this patient, I don't want that these are what I call the slave bomb. You know, there was this song, the sexy bomb. I don't want to sing it, even though it's a
Let's
concert.
do
So
it.
the slave bomb is the typical dentist, the typical patient that breaks here, breaks there, and you know what they do? They do the 1st of January, the Saturday night, the COVID lockdown. My goal is to
Yes.
absolutely decrease this number of
Yes.
slaves. And this is we have to do so. Because when you see this patient, it seems that he's stable. And after bomb, fracture of the premolar. And now arrive a dentist and decide to do classical. It's a bridge. So now when you look from the distance, seems the best things to do, maybe here look that there was no bone, and they do involve a premolar that was already weak and devitalized in a bridge with the canine that was strong tooth. And now we have done just a quadrant dentistry. What about the rest of the mouth of the slave? And the question is, there was the little bomb. Should it be the moment to tell the patient, I extract, you stay with the whole. If you don't do the full global project, go somewhere else. No, there was a dentist that accepted to treat for single tooth and give the bridge. And the bomb was, I don't know how to call these things, was lighted. I don't know in English.
Fuse. Fuse.
The fuse was started. So
Yeah.
how long do you think? What do you expect to happen? What is the next call of this patient, Miguel?
Uh,
You
I
have
don't
a
know, but
premolar,
not.
you have a canine. How long do you think
I'm
it will last?
I'm still thinking why a post was placed in it because I don't do posts, but that's a different story. So it it's a short-term solution, Francesca.
What break?
In
What did it
it's
break in him?
something's gonna give, and it's probably the premolar.
Mm.
Oh my goodness! Yeah, look at that.
Oh no, I have,
Look at
you
that.
see, oh, see, this is Condilo, my cat. And now Condilo normally start to eat all the cable. So if this concert suddenly does a poof and you see black, you have to blame the cat because it's not us, the organization, it's the sabotage of the cat that wants to eat. No, actually, I don't. It was not the premolar, the fail. The fail was the canine. There was a vital tooth, and after that, the bridge became dislodged. 5 years later on, it's such a short time. And now what? Now what? Who's gonna take care of this? Because is it taking care of just a student can face this type of mouth? A general dentist is trained to do this type of mouth? It should be a specialist. But the specialist is expensive and maybe this patient does not have money. So it would be better to keep this patient, to stop this patient before then he deteriorate. But for sure, the best was not to create slave bomb because they sooner or later explode and life is too short to be after the slave bomb. And so you agree with me that we want to work with the highest percentage of tooth structure because we become a better dentist. The Gisele dentist is based on percentage of tooth structure. If we wait and we let the mouth degrade, of course there is always somebody capable to place an implant. but even in the wrong place. It's not sufficient. Here we need a global vision. But let's make a test. All of
Let's do
you
it. Let's do it.
connected. Then look at this guy. 1, 2, 3, 4. Which teeth did you notice first?
Uh,
Don't. Which
as a
teeth?
dentist, or as a lay person.
As a patient that smiled to you in your office. Which one?
The moment I saw that slide, and it's the first time I see it, immediately as a dentist, the posterior lower molars. But that's not that the lay person will see, neither probably the patient.
So, do we agree that the majority of the people
Yep.
are there to communicate to the
Yep.
patient that there is a huge problem on this incisal edge? And most probably the posterior are even ignored because not important even for the dentist. That is what it kills me. Because for the patient, for sure, they are not important, but the dentist should know better and not
There's so
let
many.
the.
There's so many friends logged in right now. You have no idea. We have Marcela Cardona, who's an amazing prosthodontist from Orlando. We have uh, Lourdes Socias from Dominican Republic. I'm a little bit jealous because she says, Francesca, you're the best, but she didn't say nothing about me.
But because it's a pink solidarity, woman bond. So when you see, guys, the white panoramic, and she is 50, and she comes for the front teeth, here is where we should look and concentrate the attention. Because when they come and become 60, here we start to miss teeth and miss bone. And suddenly we find somebody in their 80s and we say, how did it happen? It was inevitable. And this a video for you to show you how this lack of posterior support is essential for the front teeth, because we always say that the anterior protect the posterior, but it's the opposite. It's the posterior teeth that protect the anterior. So if they don't have, if you start to test the chewing, you will see how many people chew even on the front teeth when they have a premolar occlusion. So a must. Preservation. It cannot happen that we take somebody like this and half an hour later is like this. This cannot happen, especially
We're on the
because
same
this
page
girl
there.
was 27 years old. And because this type of dentistry fails. And removable are removed. And there is an overload on the front teeth. If you see, these people don't chew on their removable. So the global vision is a must. But for us, not only for the patient. And it's difficult because everybody wants the 6D. The 6D is 6 anterior teeth dentistry. You think that the patient is enough educated to start to talk about aging, posterior support? They don't know. But we are supposed to be clinician, doctor, to inform that if you just repair the incisal edge, but you have not addressed the cause that has broken, they demo. How can we think we do better? Trust in bond, trust in material, the hard. It's not possible. We need to protect the restoration. Otherwise, it's set to failure.
I mean, it's very important what you're talking about, because you started by saying, hey, a lot of us hate what we do, and we hate our Monday morning when we see that this is coming to the door. And most of that are the cases in which we find ourselves being the fourth doctor, being the 10th doctor, being the one who has to work around this dentistry that was done one by one, piece by piece over the years. And we're also guilty that we're also going to contribute to that for the sixth doctor. And what you're trying to tell us now is, guys, from the beginning, we need to stop doing all this crazy dentistry because we need to think about that fourth doctor. So if we're the first doctor, if we're the second doctor, we need to start looking at the forest. We can't start denying. We can't go to the case that you showed, that smile with the mouth open that I said, let's look at the molars. You can't just ignore that that patient needs to be informed and protected of what's coming 20 years from now if we don't address this. And we can't just keep saying, no, I don't, this patient, there's no way they can pay for 20 onlays or 20 composite direct onlays, and they only tell me that they want the front. We need to warn them. Look, when I took the Botox course to learn how to do Botox injections, it was amazing to me to see how all the models and all the females that were taking the course from the provider side, when they started talking about themselves, many of the things that they were saying, and they're in the 30s and 40s and 20s, is they're doing all of this to protect for the future, right? Botox is now like, if you get Botox in 20 and 30, in the future, you're not going to have as many wrinkles and you're also going to look better now, right?
Yes.
Why do I think that the same person cannot understand that I can talk to them about their teeth and what's going to happen 20 years from now or 10 years from now if they don't at least evaluate what I'm going to put on the table? Again, I'm going to go back to the point that because most of those conversations feel like a waste of time for us, we tend to stop doing them. And I think we should continue to do them.
Because the patient is not prepared and is hard. I want to just show you this woman that has a failing 6 teeth, a fixed partial denture.
Don't worry, she'll be right back. Her camera turns off
He came
every
to me
once in a while.
and no, it's not the cat. He came to me and she want me to remake this, and somebody will start to look about the gingiva, the transition, the mamelon, and I just start to look away from there, and I say there is a problem. This anterior garage, for who follow the three-step neatology, is in conflict. And if there is a conflict, this is the reason why this restoration failed, and it will fail the next one. So I need to do an early intervention because I want to intercept her now, and not like these other dentists that did not intercept, they even devitalize the teeth because they were becoming too sensitive. And all of them are always lack of posterior support. So in this woman, there is no discussion even to remove the failing bridge before we provide a posterior support. So I am strong to tell her global dentistry or nothing. Life is too short for the slave bones. And the patient walk away. And I say, okay, because I have the awareness that without the posterior support, it will fail. And 6D dentistry, it will fail. Because and this awareness is because of I want a quality of life, my life. So with this patient, they come and want 6D, and I say, let me see, because I can see that you are breaking the enamel here. And when I look, I see removable. And I say,
Yeah.
posterior support, and I look at the panoramic. And I say, no, what is left is not good. So ladies, we do a bleaching in the front and you invest all the money in the back. And she told me, sorry, I'm not interested. And she walked away, and most probably she's with another dentist that is doing the 6D. But no me. And so when I gave my courses about the three-step, all the dentists that bring their case, they start to be aware that
Yes.
they have to stop and think in a more global. But this global vision, it's hard to do because the dentist that does a single tooth should not plan. You just have to know if you have the material, if you have the things to do the extraction, the root canal, the little things from the laboratory, but no big planning. But if you do a global, you have to plan before, while the dentist is so used to go to the treatment because the slave dentistry, you have to rush the dentist, the slave out of your office because the slave enter in your life as an emergency. It's not a program. It just call, that bridge is breaking down. Okay, boom, out. There is no time to think, to change the condition. And this is, Miguel, the project of the laboratory technician, because the question is, who did the project if you are doing global? Who did the project? Because once I was teaching to this group of future prosthodontics, and I was like, can I see the project? No, look, the mock-up, because now it's very fashionable, the mock-up. I said, I don't want to see in the mouth. It's too late, because maybe you are proposing something wrong to the patient. I want to see in the project. You as a prosthodontist, but even general dentists, should see how this is before it's here. This is already even more too late, because what you think the lab technician can give you, he's try his best, but this is a fake patient. This is just a 70% of the reality when you see everything on the articulator. I'm not a big fan of tradition. I am a big fan of the natural articulation. So when you see all these cusps that during chewing avoid themselves, you know that there is much more that we should do on the articulator, and it's not possible. It's not possible that this cusp has the perfect inclination in the mastication. It has to customize with the test drive. And many of these provisional don't look as the final shape. They look flat, and the patient say, oh, I'm okay. No, because it's a piece of plastic and you are just surviving. But once you give zirconia on implant, there we will see your real nature. Because when you see this man is 30 years old, he came to me and he said, my lateral veneer debonded 8 times. So the slave treatment was to rebond. The free man was, let me see, he was already accused to be a Braxer and the patient was just erosive. And so he was in his mind that he was impossible to be treated. But when I look, this lateral was against the big canine and the anterior garage was completely locked. And there was no posterior support, set for failure. Because this is what we have to make clear. We have to stop talking about rehabilitation. We just have to say that we are reconstructive the mouth. Well, every time I see a beautiful reconstruction, crown, veneers, it's beautiful. But if you want to know if it's really also rehabilitating the patient, you need to show the function before and after, and the function after should be improved if it was wrong. And this is called gnatology. We have already discussed with you, Miguel, that the people hate gnatology. They say, I just do aesthetic, because we make this so complex that people don't want to hear anymore.
Well, because he became dogmatic.
Because
It became dogmatic. Natology became dogmatic for many people. Many of the people who started natology, they were the ones who trained the ones who are now very old and into natology, and they have this respect for the founding fathers, and they became too rigid. I'm not talking about if natology is good or bad, please. But I'm saying I'm talking about why natology got a bad reputation at some point is because they became too rigid and it was their way or no way. And many of the generations coming after that were saying a lot of what you're speaking is true, but there's more to it.
so this one is a reconstruction. This is a real patient, and many will look at this reconstructed model and they will say the margins are fine, the occlusion is fine, but the rehabilitation of the patient is something different. So if this patient needed 18 appointments to check occlusion, and for 3 years is still not happy, so it's not that it's finished, it's still not happy, maybe it should have been before test driven. This is the secret. So let's see instead what the poor dentist, because the poor dentist 3 years with the same patient want to kill himself. So this is what was underneath the reconstruction. So what is the things that could have been done differently? First, full mouth, final restoration. So he took basically the whole maxilla and most probably the mandible and delivered the final restoration. They were in ceramic. Ceramic does not forgive. The test drive should not be in ceramic. And subtractive dentistry. This one, no post, Miguel, but if a function is not correct, will be debonded. So if you do subtractive mistake, and this patient is 3 years with you, you cannot say, hey, you know, it was okay, I tried, can you go? No, it stay with you. Remember this picture. Married with children. Because you cannot let these people say, okay, shake hands, go. I tried. No, because you cannot bring them back to the original. So if you take this woman that she just said 27 and she would have been perfect for what you will see later on. So she had this beautiful dentition, and it was good the intention of his dentist, because should they be treated, should they be intercepted, because with erosion we have to treat them, but not like this, not like this. We cannot devitalize the teeth from second premolar to second premolar. This is not the treatment for the lower incisor, that they were healthy. Why they deserve this? Do you think they will last longer? This is the way we protect teeth. After 3 years, these 3 teeth are already slave bones, fracture. She's 29. After that, I don't know what happened to her. But if you want to do a global dentistry and propose this type of treatment, nobody will accept. Everybody will accept only if they arrive at the level of catastrophe that they say, okay, now do it. Because the pain, subtractive dentistry is not nice. The time to devitalize all these teeth, to do first set of provision, second set of provision, and the money, who has the money? But especially for me is the lack of stability, because this is a patient, he was in his 50s, and I just started to work in private practice in Geneva, and he came like this with this picture. And I look at and I say, wow, I can do miracles. And he showed me, he say, I'm a very busy man. And I went in Lebanon and they did this treatment in 2 days. And the dentist told me that I would have finished in the same time. And he was like this, lack of posterior support, but I would have immediately repaired all the palatal aspect because they were fracturing. I would have stabilized him with no even anesthesia, but this is what he received. In 2 days, Miguel, they devitalized all the teeth. But the problem now is that from here to there, there is nothing to grasp the provisional. So what do you think the provisional did? Lost 3 times. And this provision lost 3 times. All the endo were infiltrated. And this guy does not have time. He travels everywhere and does not have a posterior support. So remember this type of chewing. So this provisional, of course, was a slave bomb because it was meant to be also an occlusal, the posterior teeth. So it was dislodged just by chewing, not because the patient was a Braxer. I never see the patient, but I'm sure this patient, because he's in a rush, somebody extract all his teeth and place implant. Because this is also what the patient receive when they want fast and furious. But now he cannot have fast and furious. Each root canal should be redone, post and core, crown, provisional. So life is miserable. And I don't want to be at 10. My life, my range of my patient is between this. I don't know where you are with your population. Miguel,
I'm about the same. I will put a 4 sometimes for a couple, patient with a pain and root canal sometimes, but I'm about a 4, and I'm about 1 to 4 by choice. I continue to say this. I'm about 1 to 4 by choice, and I am with you on what you're saying, which is how many of the 7, 8, 9s, and 10s that we see that are making us miserable are the result of somebody in the past, another dentist, beginning a path of treatment that 20 years later led to this. And what you're trying to tell us right now is like, okay, now we are also that dentist for this patient that in 20 years has to look like something. And what are we doing today that is going to make this patient be a miserable patient 20 to 30 years from now? And unfortunately, classic prosthodontics might be, on a global view, not well focused. And I'm happy that the new generation that are coming out with me and with other people out there are starting to question this. Do we have to crown everything? Do we need a post? Do we have to do root canal? Can we move this instead of doing this? Can we do additive composites? Can we do additive ceramics? Do we need to do all this dentistry because natology says that the cast and the fossa and this and that has to be, or can we understand that what we do today has a consequence? And I think where you're going is you're right on.
And now I want to say goodbye to you because now we go into the second part of the concert.
Yeah,
And I want to thank where I
no
will
problem.
explain not only now the problem we have faced, and I was very happy to share with Miguel, but now we enter in the 3-step. Miguel,
Yeah,
it was a pleasure to hear
for
from
sure.
your side because that don't leave me always this impression that I'm a troublemaker, I'm an extremist, I'm a woman, I'm a crazy.
Then you invited the wrong person. If I needed
Okay.
to balance that out, we failed.
So no, that was perfect, but you will pay the consequences because
I
I
will.
think the majority don't think like us, and I would like them to be open-minded. If your type of dentistry, you love it, keep doing. But if you, like Miguel and I, want to get out of that complicated life and make this job a much better job, follow the second part of the presentation. Miguel, do you want to make a final remark before
I
I
do.
take over?
I do. I do. I just want to say thank you very much for having me in your concert. It's been a pleasure. I think you have set up what the problem is, and you have discussed very well how, from the dentist, when you feel or not feel that you're miserable, and why these patients are appearing in our chair as miserable patients to treat. And you have set it up to say, hey, can we take a global view of this topic? Can we stop just treating the patients as slave and only what they need? And instead say, no, right now you need more. Because if you don't do more right now, which doesn't mean that we have to be super rich for it, because you can do additive dentistry. If you don't do more right now, in the future you become an angry 10 that we don't want to treat you. And that is our responsibility. And this is the beauty of what you've been doing with the three-step system, which is I am a prosthodontist, you say, but I am not the girl who goes cutting teeth all over. I've been doing another kind of dentistry for years, and I want to share it with everybody, and you're doing it free on YouTube. So, and for you to make me part of it is a pleasure. You're killing it. It is going awesome as I promised it was going to be. And I see everybody in my account or wherever you want to see me soon. Thank you, Francesca.
Thank
It's
you.
been a
Oh, thank you, Miguel. Okay, guys, now we go with the second part of the concert, where I will talk about solution. Solution is because, again, life is too short to be miserable. And in 2004, I had these two beautiful persons enter in my life. In my life, no?
Drink something.
Eh? I had no, I had this beautiful man in my life, and now they completely changed my life. That was not well, and now I think the revolution has started. And the revolution is to take pros and restorative dentistry and meet halfway. And that halfway is called the three-step. So the goal is to take patients, they are not so destroyed, and to start to protect the posterior teeth, preserve the posterior support to prevent further damage to happen. And this is the three-step philosophy, the three-step method, the three-step approach, whatever you want to call, but it's not a technique anymore, because the three-step is a full package. So first you have a diagnosis. You see, this is a fantastic concert where I have my assistant bring me champagne. It's not champagne. Grazie. So the diagnosis, because we need to know why the original is breaking down. Second, the laboratory project, because we need to guide the laboratory technician. Third, therapy. Therapy done as test drive reversible. So let's start. Diagnosis. This is not an emergency in the sense that I can take the time when the patient comes, not to take the impression to restore this, no, to remove this crown, to place another one. Stop and think why this is fracturing. Think about why this enamel is so overloaded, because the next will be another failing, and if you put something harder, something else will break. So the diagnosis is what is the difference from the treatment of the slave and the treatment of the free man. the free man has a diagnosis. Beautiful anterior teeth, enamel is breaking down. Let's stop and think why. So, because we want to tell the patient that there is a problem now to prevent further damage. And so if you are trained during this initial contact with the patient to know the details, the sign of the future problem, you will be a better communicator. So you see that there is a reduced overjet overbite. It means that the garage anterior garage is in conflict. There are signs of erosion that make this beautiful enamel fragile. And there are dysfunction associated. All of this could be tested. And in this consultation, you become somebody that really make the free man educated, because nobody has spoke to them about their problem. And at the end, very few don't care. The majority care. Because you do simple tests. You say, this beautiful enamel, why should it be fracturing and it should be a slave bomb? I don't want to put the veneers here because I know this veneer is set to failure. But how do I communicate to the patient? Let's do the famous G test. And now you should know. So if you have made a diagnosis that the anterior garage is in conflict, it's not intelligent to put the door even longer and thicker. It will break. How do I explain to the patient? I take a little flowable composite. The patient wants just 6 teeth, and I say 6 teeth will fail. I don't believe you. Yes, let me try. No even discussion. Let's put this little composite flow, polymerize, not etching, just polymerize, and give a gum on this side. And the patient start to chew, and they can feel immediately the anterior garage in conflict. And so they can experience that what you say it's right, and they can see the future of the restoration. If they are done without changing the condition that has brought to the breakage of the enamel. So this is, you become somebody that explain much better to the patient, communication with the patient much more. So let's give me another example. This patient arrived and somebody has taken the incisal edge and decide to do crowns and devitalize the 2 teeth. You look and you say, okay, global vision. This dentist did just a single tooth dentistry. Let's look. Ooh la la! Anterior overload. Why this crown? If they are overloaded, they can make the end of the 6-unit failing bridge that I showed you before. So let's look. How is the posterior support? Ooh la la! We have a generalized erosion. And so there is a lack of posterior support. And what happened? This one is not fracturing. Is this that is getting in trouble? How do I talk to the patient? Because the patient don't care about gingiva. So, 2 cotton and quick deprogrammation of the patient. Just what you see, a real story, 2 cotton, ta 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 ta, remove, deprogramming, quick the mandible, anterior contact. The patient look and say, oh my God, now my crown are at risk, what should I do? And you say, okay, let's do a 3-step. And the 3-step is accepted by the patient. Why? Because the 3-step does not have pain. Is additive dentistry. We don't cut teeth. We don't even remove existing restoration because we want to work with the not anesthetized patient. Why? Because we really check occlusion and function. Time, the three-step is quick because again, I don't do endo, I don't do crown lengthening, I don't remove existing restoration. And money, I recycle restoration. I do composite with a transparent key, so I know there is a full mouth and the patient many times cannot afford. But with this transparent key, I can really do a great job for the patient. Interception, fracture incisal edge, no single tooth dentistry, global vision, bigger problem. Patient not aware, convince the patient with the three-step technique to show that there is a problem. So education to create more free men, the patient accept. T-Tech, the technique of Dr. Puma that allowed us to make this white bite done with the transparent key, most probably able to open by themselves the contact point, interproximal contact point. And this, of course, cut off the cost of the therapy. And if one contact point will not open, you do a direct composite, here you strip, and here you do a filling, and the patient will pay. But you know that here you have 1, 2, 3, 4, 5, 6, 6 out of 5 would be, 5 out of 6 would be perfect, and just one payment for a direct composite. So the patient can have this direct restoration and quickly done with no anesthesia, because the goal is not to open the contact point in that visit. The goal is to stabilize the patient, and the patient not anesthetized does not have pain and is ready to check function. And once we have opened the anterior garage, because we have placed the posterior white bite, now we have the space to store the anterior. And which material in this erosive environment? Well, we will be discussing with Roberto Tello about the adhesive anterior restoration. In that specific case, I select palatal veneers, and I select also this specific material that is CAD/CAM composite that I love the most. I started to believe in this composite. Now I have a follow-up that you will see even at 8 years, and I think these are the future, especially for dysfunctional patients. The three-step is better, is reversible. This project is reversible. What does it mean? That I have the luxury to do mistake. So I take this patient that needs to have a new occlusion. We cannot let him degrade. I do the transparent key and I give him a new posterior support. But with him, I was not good in rehabilitation. He was uncomfortable, and I say, okay, please don't make me do adjustment. At the end, he asked me to remove everything, and I went back to the initial. So this is the luxury to take him from here to there, and this is reversible. How much time it took me to do this? Not so much. But what is the good thing is that I was not married with children. So I just tell the patient, sorry, I try, you can go. And this gives me the power to try. Because if I can be not married with children, I can take patient that nobody wants to treat. The stress patient, the bruxism, the what I call dysfunctional wear, and I can give a try. I say, they cannot stay like this. The enamel is failing, so I don't want them to become like this. I want to intercept. Somebody would say, okay, but you can keep them with the bite. You're right, but I can also propose them a three-step additive. Is a choice of the patient, but I need to be aware of what the patient I have. These are not erosive. This population is called thick and flat. Their incisal edge with time become larger and stronger and still is worn down. So the force on these incisal edge are huge. And so who are we to try to restore these people? Again, awareness is the key. If I'm aware that these thick and flat have the incisal edge all their life at risk, my therapeutic choice would be very wise. I can see that their incisal edge is always a risk. I was always looking at them and say, why they are on their incisal edge? And I'm a very curious person. I was like, why they are always on their incisal edge? They even have a posterior support. Well, why they go forward, forward, forward? And suddenly, he hit me. Because there are other clinicians that start to realize that this population is aging in a special way. And unfortunately for the thick and flat, they age like these old men in protrusion, edge to edge. This is what has been described by Pedro Planas. They age and there is this mandible that slide forward. So there are people that say this is pathology, there are people that say no, it doesn't happen. I see my patient, they are always on these anterior teeth. So who am I to go against their neuromuscular nature? But I don't want to let them stay like this because I know that they are deteriorating. And I am even thinking to change these anterior teeth because everybody wants the anti-aging. So you see on Facebook, on Instagram, all these cases that there are people take and make a longer teeth. They don't fit the patient at all. I never see follow-up. So, flat and thick is a specific population. If you want to follow my advice, only additive dentistry, because they will always have this incisal edge at risk all their life, and we cannot win their nature. So, thick and flat. And which is the project? The project is, don't put in the patient head that he has to have this beautiful 12 millimeter. He doesn't care. He doesn't want longer teeth. He just have here a little bit broken. For the rest, is fine. And I want to keep it fine. But I see actually the antagonistic. And I say, ooh la la, we need to protect them because they are evolving not in a good direction, and this patient is 30. So I'm thinking 50 years from now, I'm a dentist that intercept. And when I see his bite at night, he is somebody very active. And so when you think about posterior support, are you placing ceramic? Are you placing composite? I don't have the answer for that, but my first test drive is always in composite. In this patient, I went with CAD-CAM monolithic onlays, 6 on one side, 6 on the other side. It is following the 3-step, and I gave all to the mandible. The maxillary was not touched. the posterior. So it's called one arch distribution. Increase the vertical, give everything to the mandible. And so now I have these beautiful teeth. And you know what I did? I just sealed the dentin, like Pascal Magna taught me, and took the impression, no even anesthesia, no even losing one prism. So there is no preparation. This was 2013, and we experiment these CAD-CAM monolithic composite veneers that somebody will say, not beautiful. This is beautiful. And this is 8 years later, these CAD-CAM composite are aging fantastically. Are you looking at the moon or are you looking at my finger? Because why should I present to you amazing work that I don't do in an everyday private practice? Do you want to see amazing work? Crappy, full adhesive rehabilitation. You have to remove all these zirconia veneers. You have to re-prep, and we decided in this patient to go with the feldspathic veneers. But do you think I should do this subtractive and feldspathic or any type of ceramic to this patient? Because my awareness is that the diagnosis is that it's thick and flat. The awareness is that it will age in protrusion. And I will always have this anterior teeth at risk. So why would I make, in this picture, place ceramic? For my ego, not for the benefit of the patient. So this is the patient 2013. This is the patient 8 years later. And what I did was just 2 little composite on the lateral, and I did not tell him that it's not beautiful. And I stopped to feel uncomfortable, because there was a time where I was giving lecture about these people in my presentation, and I was always like, the little poor girl with the ugly cases. No, these cases are beautiful. You know why? Because you could do Monday. With CAD-CAM monolithic composite, you don't even need to select the color, and if one of those composites fell off, you can do immediately. You don't need big intervention. And the response of the patient to this type of additive treatment, they are amazingly happy. So they go around jumping and telling everybody how fantastic you are. Thick and flat, protrusive attitude, 2 different treatment plans. This was subtractive. The dentist told the patient that he should have received 2 years of ortho, maxillofacial surgery, mucogingival surgery, 12 elective endodontic crowns. And somebody told him, hey, I know a crazy dentist that does weird things, go there. I look at him and I say, wow, you look fantastic. And he said, nobody told me that is so happy to treat me. Actually, people were pretty scared. I say, hey, a 3-step, you should give a 3-step to everybody. And I say, in 5 visits of 2 hours, 3 hours, with no anesthesia, I fix you. That is 3 years work. This is 5 visits that was done in 1 month. Posterior support with CAD-CAM monolithic, and this patient received 6 facial veneers, monolithic CAD-CAM. Would you trust this little guy with the patient that is always in protrusion? For sure, never, never a post, never. I prefer that is the bond, and I rebond. But before I rebond, I recheck the occlusion, because that is the weak link that tells me that there is an overload. 4 years. Voila! Beautiful, beautiful. Let me tell you, if you are looking at that is a little bit thick, the edge, you are missing the functional point. And if I show you 7-year follow-up with picture that I don't even take with the bouncer to make it beautiful, it's just a normal follow-up, the way they come, I take a picture. So the only problem that I have with this patient is budget, because this is the full mouth. Otherwise, everybody, me, myself, I want a 3-step, I need a 3-step. So everybody should get a new layer. So why the 3-step could be good in money budget? Because we can stage the therapy. How do we stage the therapy? We don't remove the restoration. So look at this patient. There is no way that I start to remove all these existing bridge, even if they are in gold and maybe the composite does not lock well on gold. I just don't want to deal with removing and be surprised that maybe the abutment are no good. I want the best foundation, and for me the best foundation are the existing restoration. Thick and flat. Protrusive attitude. We need a additive 3-step. What would you do here? Do you think you are going to devitalize this teeth? No, no, no. Don't touch this patient. Add. All their life they should be protected by themselves. So if this patient now has 40% of the tooth structure, your goal, my goal, is to preserve like a little baby this 40%. And how we do? We keep it the way it is. We don't remove anything, but we use this fantastic transparent key, and we sandblast the bridge, and we press with no anesthesia. So this patient was with me with no pain. He received the whole treatment while he was sleeping on the chair. And this is the final. Everything CAD/CAM monolithic composite. Are you looking again at the moon or the finger? Because you have to think about it. What you just see, what is underneath? No endo, no post. These teeth are kept vital. So this mandible was completely deviated. The patient could not find his position, and in 3 appointments, in 2 weeks, he's like this, center and stable. So how fast is the 3-step? Extremely fast. The patient could not even bite, didn't know where to sit. After the 3-step, no anesthesia, 3 visits in 2 weeks. It's amazing. And now, is it finished? No, now it starts the additive test drive. And so now we need to rehabilitate with what we place in the mouth. We have to check the function and reshape. So people that tells me, oh, I put the restoration, I never touch, it means that you don't do this type of occlusal adjustment. Otherwise, it's impossible. That is, the lab technician provides you something that is so customized. It's like you have this beautiful dress, and this, you get the first measurement, but after more you wear, better your haute couture will be. But cannot be done on the mannequin, it should be done on you. So a 3-step, it's for everybody. I am so convinced that it's Saturday night and I have the enthusiasm of really a real concert. So all these people get a 3-step. And why? because I think I want to have my professional life much better, because my time is better. All these people are on a schedule. The three-step has a very precise protocol. My assistant knows exactly how a three-step is done. All the three-step. Money, yeah, I don't place implant, but how many three-step I do a month? A huge, because they accept these people, and these people should have come just with 6 teeth, and I propose the full mouth. And after this population become attached to you, they they are afraid, my patient, that I will take a retirement. There is an 8 years old, they keep telling me, please don't retire, because I don't know who's gonna keep doing the way you work on me, because they know that nobody does additive prosthodontics, nobody. Guys, everybody does aesthetic, facial veneers, crowns, implant, everybody. But if I have a son or a daughter in dentistry, there where I should bring her to additive prosthodontics. And you know why? Because her life or his life will not be miserable, because the best part of the three-step is that I don't produce slave bombs. I don't produce slave bombs. My goal with these people is to intercept them, to protect and to preserve the percentage that they have. And I call for the anterior, the restoration are aging fantastically. For the posterior, I speak honestly to the patient and I say, I just give you a tires. I don't know what you do with those tires, and I cannot give you the original, the enamel. I give you a repair. So if I cannot improve your function, but it's not a 1 year, it's a lifelong control. If I cannot improve your function, you will have maintenance to do. And so which are the breakage in a free man, the emergency? 5 years follow-up, this molar has this, that has been intercepted during a control. The patient did not call and say, oh my God, I'm dying. No, very control emergency. And I can polish, I can do a direct composite. If I have the piece, I will rebond or I replace. But I replace, and this my goal, that this molar will stay always as an onlay, additive onlays. They will never go like we do with subtractive. We start with the crown, after we devitalize the tooth, after we do a crown lengthening, after we do another crown, after we extract the tooth. So this is the end. My goal is that I keep the whole percentage of existing tooth structure. So if you think about it, Dr. Lang, Dr. Lang should rewrite the article on additive prosthodontics, because honestly, who can do this type of repair? Everybody. So if 10 is the simplicity to do this job, the patient anxiety is like, he doesn't have a zero anxiety. Is perfect. Time pressure, these repair are in my office like very little emergency, so it's really no time pressure. Economic pressure, my patient knows that they have a issue. I am comparable to an endocrinologist that is treating diabetes. I'm not curing the diabetes, but with the restoration, I'm making the consequences of the diabetes go down all their life. And this is what I say to this patient. You are losing by yourself for your muscle that I cannot control, your enamel. The three-step is a 24 hours bite. And so the patient pay for this. So there is zero economic pressure on my side, because the patient is an educated free man that knows that has to pay for the repair. Occlusal adjustment, with the 3-step, you have already started to learn how to do occlusal adjustment and the importance to do occlusal adjustment, because if something is reconstructed but not rehabilitated, soon it will fail. And if you check occlusion with the way, with the G-test, with the cotton work, the patient will guide you for the little repair. Type of emergency? Peace and love. So again, I think now we have a choice. 2 types of dentistry, and I selected the one that make me sleep at night. Her life is way too short to have this panoramic with so much white. This is a world different. My professional world, it looks like this, and is based on awareness. So if you want to be part of this world, some of you will start already the process. So I know among you it will be the lucky one that already next week will be entering in the 3-step world. The 26th and the 27th of March we start. 2 days live streaming in this type of setting with me. Hard, intense training, and the second moment that we meet again for the course number 2 will be the 7th and the 8th of May. And I think I love to do this type of interaction because thanks to this little board, we communicate much better. I thought online would kill the ambience, but you on Saturday night, you are awake with me, so no question about it. The 3-Step Academy is our web where you guys can look. It's completely a mess because Gisele is creating a new one. I want to thank so much Gisele for doing that. She's a fantastic assistant. So give us the time until April, and we are coming out finally. And finally with this much better website to get you to the e-learning. The next step would be to keep in touch with us, would be the concert. You saw the first one, but we have planned to have the other every month on Saturday, because I'm in lockdown. I don't know if after the last one we will still have this opportunity. The 24th of April, 22 of May, 12 of June. The Tello, August Brughera, and the Aoshima, Tetsuya, will not be at night because we want to give to the Asian, the Japan people, the best time for them. So it will be in the afternoon. So to conclude, during this concert there will be a lotto, a special prize, and the special prize will be the online video lecture. So I will extract the name of the lucky person that will receive this online lecture. They're always available, and I think for some of you that don't want to do the face-to-face or the live streaming course, get some of this, because this is from the picture, how to take a picture for first consultation, how to increase the vertical. You need this training. But next moment with us will be 24th of April, 9-11 p.m. with my friend Roberto Tello, and we will be concentrating on the front teeth. So what to say? Guys, I will get the feedback from my people like Pumix, Gisele, once we shut down everything. If it was okay, we can calibrate, we can do better. Now I think it's time to say goodbye, and it was my pleasure, I hope your pleasure too, to be with you for this Saturday night. So thank so much for being with me, and stay bonded and walk with us.